Continuing our topic, restrictive lung diseases, after we acknowledge you that tests must be done for patients with restrictive lung diseases can be categorized according to the type of the disease that we are considering, whether it's an intrinsic lung disease or an extrinsic lung disease. We will do chest X-ray, CT, scanning, and other preliminary investigations, and it differ according to the different conditions. So CT scan is very important and must be done before doing pulmonary biopsy or lung biopsy if it's indicated. So CT scan is used for the diagnosis of lung fibrosis, idiopathic pulmonary fibrosis in the setting of classical clinical picture of idiopathic pulmonary fibrosis and classical findings in the CT scan without the need for lung biopsy. So other tests are pulmonary function testing, and we all know that pulmonary function testing is a very important method for distinguishing restrictive lung diseases from obstructive lung diseases, and we have a whole lecture about pulmonary function testing, and we elaborate on explaining that the different types of testing and their physiological bases and their clinical implications. So here we will go through the important pulmonary function testing that we can do for patients with restrictive lung diseases. Complete lung function testing includes spirometry, lung volume, diffusing capacity, and arterial blood gas measurements. So there are 4 elements: spirometry, lung volumes, diffusing capacity, and arterial blood gas measurement. So with the spirometry, we measure lung volumes and capacity, which is static and dynamic lung volumes and capacity. Diffusing capacity, we measure it with CO, and arterial blood gas measurements, we do it via the blood gas machine. So pulmonary function tests do not indicate specific diagnosis or help distinguish alveolitis from fibrosis. So if we are talking about a restrictive pattern, and this restrictive pattern showing limited diffusion in the lung, so this cannot differentiate between alveolitis or fibrosis. So the pulmonary function test does not point to the specific disorder, to the disease itself, but points to the pattern, whether it's restrictive or obstructive. If it's restrictive, whether it's extrinsic or intrinsic. That's it. So pulmonary function test can show you whether it's obstructive, restrictive, or mixed. If it's restrictive, whether it's intrinsic or extrinsic. So obstructive means that the ratio is low. Restrictive means that the ratio is normal or high. Intrinsic means that there is impaired diffusion capacity, and here is normal diffusion capacity and problem with the maximum inspiratory pressure. So all disorders are associated with a restrictive defect with a reduction in lung volume. So restrictive disorders are all associated with decreased total lung capacity, functional residual capacity, and residual volume. And the findings of the test are invaluable for monitoring the course of the disease and assessing the response to therapy. So they are very important. Reduction in the forced respiratory in the forced expiratory volume, FEV1 in the first second, and forced vital capacity with a normal or increased ratio suggest restrictive pattern as we said. And the diagnosis of restriction is based on a decreased total lung capacity. So we cannot say there is a restrictive lung disease without a reduction in the total lung capacity, even though if the ratio is normal, because the ratio is normal in normal subjects. So what's the difference between the normal subject and the restrictive lung disease is that the reduction in the total lung capacity, but the ratio is still normal. A reduction in the forced expiratory volume 1 and the forced vital capacity, both of them. So the assessment of the severity of restriction is also based on the total lung capacity. So we're going to say this patient have a more severe disease than the other based on the amount of reduction in the total lung capacity. As we mentioned in the previous lecture, we classify the patient for the obstructive if there is a severe reduction in FEV1 alone more than the FVC. So we classify the severity here in restrictive lung disease based on the reduction in the volume of total lung capacity. So diffusion, a normal diffusion capacity of the lung of carbon dioxide or carbon monoxide in the setting of restrictive lung parameters suggest a chest wall or neuromuscular disorder. So after we do pulmonary function test and we isolate the patient or classify the patient as a restrictive pattern, then we do diffusion capacity. If the diffusion capacity is normal, this indicates an extrinsic cause. If it's abnormal, this indicates interstitial cause or intrinsic cause. So obstructive airflow limitation may be seen in patients with sarcoidosis or LAM or hypersensitivity pneumonitis or pulmonary fibrosis concomitant with obstructive pulmonary diseases. So these are the disorders that mainly cause interstitial lung disease and restrictive lung disease, but can also lead to obstructive pattern because of traction bronchiectasis. So these are the diseases like sarcoidosis, lymphoangiomyomatosis, leiomyomatosis, and hypersensitivity pneumonitis, pulmonary fibrosis, and chronic obstructive pulmonary disease, and concomitant chronic obstructive pulmonary disease with these conditions. So they are mainly a cause of interstitial lung disease, fibrosis, LM, hypersensitivity pneumonitis, or pulmonary fibrosis. All these cause interstitial lung diseases, but they may lead to traction bronchiectasis and chronic obstructive pulmonary disease pattern along with the restrictive pattern, and they will lead to a mixed picture. So we have to be careful. So we will go to see some diagrams to make it more clear. Here it's lung volumes are plotted against transpulmonary pressure. So we have the pressure and we have the volumes. So the lung volume are plotted against transpulmonary pressure, and the compliance is a change in the volume for a given change in the pressure. So a change in the volume for a given change in the pressure is a compliance, and if the lung is compliant, a small, uh, a, a massive change in the volume will lead to small change in the pressure, and if the lung is incompliant, a small change in the volume will, will lead to a massive change in the pressure. So here, from the diagram, you can identify that the low compliant lung is a yellow dotted line. So here, severe loss of compliance because a small change in the volume here, a small increase in the volume led to massive increase in the pressure. So this is low compliance. And very reduced total lung capacity. And a patient with emphysema has a higher lung compliance compared with the patient with no lung diseases, while the patient with restrictive lung diseases has a severe reduction in compliance. So this is a normal patient, normal person. The total lung capacity is here, and the increase of the volume will lead to this amount of increase in the pressure. So when the compliance is very high, like in emphysema, the this dotted line, so this massive increase in the volume only change the pressure this way because the lung is very compliant, it distends and the pressure does not increase. While in restrictive lung diseases, it's below the curve, so any low compliance will be below and to the right of the normal curve, and any increase in the compliance will be above and to the left of the normal curve. So this is volume pressure curve. Another diagram, the pressure volume curve comparing lungs with emphysema, lungs with restrictive disease and normal lung, again, but in different colors. This is idiopathic pulmonary fibrosis, restrictive disease, emphysema, obstructive disease, and this is the normal range. This is the volume, total lung capacity, and this is the transpulmonary pressure. So if the lung have low compliance and the volume of the lung reach 50, the transpulmonary pressure might reach 80. If the lung is very compliant, the volume might reach 200, and still the pressure only here 40. While the normal, the lung volume might reach 100 and the pressure still here in 30. So above and to the left side of the curve, high compliance, below and to the right side of the curve, low compliance. Another diagram show the idealized flow volume curve for normal, obstructive, and restrictive lungs disease. This is the flow volume curve. This is the flow of the to the left side of the air, and this is the lung volume. So the flow rate liter per second, 2 liter per second, 468, and the lung volume 8642. So in the normal situations, at a flow rate of 6 liters per second or 7 liters per second, the lung volume is 5. This is a normal lung volume. So, and as long as the flow is decreasing, the lung volume is decreasing. While in restrictive diseases, there is an intrinsically low lung volumes, and the flow rate cannot peak to a higher volumes because there is inherently a low lung volumes, but the slope is normal and the doom is normal. But here in obstructive lung diseases, there is a severe reduction in the peak of the flow because there is an obstruction of the airways, and we start from a very high lung volume, and the flow stop early in 3 liter as a peak, and the slope is very deep here for the reduction in the flow where the reduction in the lung volume. Another diagram is showing the expiratory flow volume curves for two patients, patient A and patient B. And A is a patient with restrictive lung diseases, idiopathic pulmonary fibrosis, and This causes the patient to have low force vital capacity but an increased ratio of the force vital capacity force of the force expiratory volume in 1 second to force vital capacity because of increased elastic recoil. While patient B is a patient with chronic obstructive lung disease. His force expiratory volume 1 to force vital capacity ratio is low, but his lung volume is very increased. You can look it this way. Here are the normal for the lung volumes, and this is a patient with restrictive lung disease. He have idiopathic pulmonary fibrosis. He have a low force vital capacity. It's the vital capacity, it's amount of air that can be expired after a maximum inspiration. So the patient cannot inspire as normal, and he have a reduced force expiratory volume 1 because he have reduced force vital capacity, and the ratio is the same. While the patient with obstructive lung diseases have a very reduced force expiratory volume 1 in respect to force vital capacity, and he have very low ratio. This is how pulmonary function tests are reported from the labs. You have to see it to understand it. This is the date, the name of the physician, the room, the gender of the patient, the height, the age, the findings of the spirometry, the force vital capacity, the force expiratory volume 1, and the percentages, the absolute amounts, the lung volumes, vital capacity, total lung capacity, residual volumes, and so the diffusion capacity, the respiratory mechanics, and the blood gases, and the volume pressure loops, and the patient history. This is how we report pulmonary function test in labs. So for extrinsic lung disorders, other tests include, depends on whether the extrinsic lung disorder is a muscular or non-muscular. For non-muscular diseases of chest wall, severe kyphoscoliosis produce restrictive pattern, so the total lung capacity is reduced, and the relative preservation of the residual, there is a relative preservation of the residual volume. The vital capacity is reduced, and the residual volume to total lung capacity ratio is elevated. Normally, the total lung capacity to residual volume ratio, or the residual volume to total lung capacity ratio, is static, because we have a static residual volume, and the residual volume will affect, if it decreased, will affect the total lung capacity, and it is the most factors that affecting the total lung capacity. So once we have preserved residual volume and decreased vital capacity, that means there is a drop in another volume. So the ratio between the residual volume and total lung capacity will be elevated because the residual volume is normal while this is reduced. So the ratio will be elevated. Chest wall components like respiratory muscle may become weak and may also contribute to the restrictive process of the restriction. So maximal inspiratory and expiratory pressure are decreased. We said that the normal maximum inspiratory pressure is 125, and the normal maximum expiratory pressure is, I think I remember it's 400 or 200. I think 200 centimeter water in pressure. So they will be reduced in patients with extrinsic lung disorders, and hypoxemia is due to ventilation perfusion mismatch caused by the underlying atelectasis and shunts. Patient may have hypoxemia and is due to ventilation perfusion mismatch. And in neuromuscular disorder, there is a main problem in the maximal inspiratory and expiratory mouth pressure from normal to severely reduced, And when the maximum inspiratory pressure falls below 30 centimeter water, ventilative failure commonly ensues. So here we have to do intubation for the patient with myasthenia gravis. Maximum inspiratory pressure, if fell, if fall below 30 centimeter water, then we have to do intubation because the patient is at risk of respiratory failure or his respiration is failing. So patients with chronic muscular diseases have a decreased vital capacity and functional residual capacity, but his residual volume is preserved and his total lung capacity is also moderately reduced. So he also have an increased residual volume to total lung capacity ratio. So breathing during sleep is often abnormal in these patients. Generally, when we are talking about sleep, the breathing and the respiration decreases because when you sleep, the central pontine centers and the reticular formation center activity decreases. So by this factor, the function of the respiratory center decreases and the activity of the respiratory center decreases, and so the respiratory rate decreases. But in these patients exactly, specifically, patients with extrinsic lung disorders, breathing during sleep become abnormal, result in nocturnal desaturation during rapid eye movement sleep, secondary to hypoventilation. The diffusing capacity is reduced in all patients with intrinsic lung diseases, but the severity of this reduction does not correlate with the stage of the disease because sometimes patients may have reduced carbon monoxide diffusion capacity but still have normal oxygen saturation. They desaturate only when they exercise. So all patients with intrinsic lung diseases have reduced carbon monoxide diffusion, but it does not correlate well with the severity of the disease. So lung diffusion of the carbon monoxide is the most sensitive parameter in finding the disease. When the lung volume are preserved, diffusion of the carbon monoxide may be abnormal. A normal diffusion of the carbon monoxide excludes intrinsic lung diseases. So this is the most sensitive finding. Sensitive means when you say sensitive, you think of seen out. Seen out, sensitivity used to rule out the disease. And if the test is sensitive, it rules the disease out if it's negative. So if the diffusion of carbon monoxide is normal, so the test is negative, it rules out intrinsic lung diseases because it have a very low false positive. So when it's positive, it have a very low false negative. I mean, so when it's negative, it means that it's really negative. Arterial blood gases may reveal hypoxemia, may reveal high ratio of dead space and abnormalities in respiratory rate. Cardiopulmonary exercise testing may be used, and 6-minute walk test with oximetry provides a measure of oxygen requirements may be used also. Medical care for these patients. The treatment depends on the diagnosis, which based on the finding, clinical evaluation, studies, and lung biopsy sometimes. Steroids, immunosuppressive agents, and cytotoxic agents are the mainstay therapy for many of interstitial lung diseases. Other therapies like supplemental oxygen, which alleviate exercise-induced hypoxemia and improves performance, may be used. So this is a general medical care for these patients. When we come to talk about specific diseases like idiopathic pulmonary fibrosis, sarcoidosis, and silicosis, for example. We will talk about the specific treatment for each disorder, and you have to know that objective data assessing the risks and benefits of immunosuppressive and cytotoxic agents to treat diverse interstitial lung diseases are sparse because direct comparisons among these agents are lacking. We don't have enough data to say whether corticosteroids or immunosuppressive agents will treat intrinsic lung diseases, even though if it's caused by autoimmune disorders. We yet don't know. This is a rich field for research and it still didn't come to conclusion. So, any question?